This afternoon, the symposium that we will have, it's about building equitable access to PSMA target radioligand therapy, RLT, across Canada. Our first speaker is Dr. Patrick Martineau. He's a nuclear medicine physician specializing in PET imaging and theranostic. He is a physician at the BC Cancer Agency in Vancouver, Canada, and an assistant professor in the Department of Radiology at the University of British Columbia. His research interests include PET imaging with special emphasis on cardiovascular and oncological application. He is actively involved in postgraduate and CMA teaching. Patrick will give his conference virtually about the overview of PSMA target RLT in prostate cancer, current and future place in therapy. Patrick, the floor is yours.
Well, thank you, Dr. Lamoureux. I trust you can see my slides.
Yes.
Excellent.
Perfectly.
So, hello, everybody. I've been asked to provide you with an overview of PSMA therapy, and over the next 15 or so minutes, I'll attempt to do just that. In terms of disclosures, I will let you know that I have received financial compensation from AAA for participation in advisory boards and presentations. However, the opinions that I'll be sharing with you are my own. During our time together, my goal is to provide you with some basic background on prostate cancer. I'll superficially review some of the most important PSMA trials that have been performed to date. To be clear, this will be a very cursory overview of very important work. And if you want to know more details about these studies, I highly recommend you refer to the original literature. I'll talk about Pluvicto, its indications, the side effects, and the role it will play in the near future for Canadian patients with prostate cancer. And at the end of my talk, I will engage in some wild speculation as to what the future of PSMA might hold. So in order to understand why PSMA therapy is so important, it's necessary to know a few basic things about prostate cancer. So firstly, it's the most common cancer amongst patients with prostates. Approximately 1 in 9 men will receive a prostate cancer diagnosis in their lifetime. In Canada, we see approximately 23,000 cases per year. Fortunately, it's usually caught early with about 3/4 of patients presenting with very early stage disease. That being said, approximately 20% of patients will develop metastatic disease. Early on, prostate cancer growth is stimulated by androgens. In those patients with metastatic prostate cancer, the treatment approach to systemic disease has, for decades now, relied on androgen deprivation therapy, ADT, in order to help control disease. This approach has an early response rate of approximately 80 to 90%. However, nearly all patients will develop progressive disease on these agents and will eventually develop metastatic castrate-resistant prostate cancer, mCRPC. If ADT was the only treatment option for metastatic prostate cancer, we'd be in trouble. Fortunately, there are a number of other agents such as taxanes, things like docetaxel and cabazitaxel, and newer hormonal agents such as abiraterone. All of these agents have been shown to be effective and prolong life and are commonly used in clinic. So here's a cartoon overview of a systemic approach to prostate cancer. If we start in the middle here, where patients are getting ADT, we see that our PSA level, which is the y-axis, will eventually climb, at which point we can switch to another agent and the PSA drops again. And then you can switch to yet another agent. But eventually, though, you enter a regime where ADT and anti-androgens become ineffective, where you've got castration-resistant disease, and then you have to resort to agents that rely on different molecular targets in order to function. One molecular target of interest and of particular relevance to us is PSMA, which is a transmembrane protein, which was discovered about 25 years ago. What's particularly interesting about PSMA is that it's massively overexpressed in the vast majority of prostate cancers. We see roughly 1,000 to 1 increase in expression compared to normal prostate tissue. What makes it even more interesting is that studies have shown that once a ligand binds to PSMA, the whole thing gets internalized and you get intracellular trapping. These features are what make PSMA such a promising target for radioligand therapy. And naturally, there have been a large number of studies looking at this over the years. An important point to note is that there are numerous different PSMA variants, which I'll get back to later on. One of the most important studies to date has been the therapy trial done in Australia with results published in 2021. This was a randomized phase 2 trial comparing PSA responses in 98 men treated with lutetium-177 PSMA-617 compared to 85 patients who received cabazitaxel. The results were very exciting. Basically, they found more PSA responders in patients receiving PSMA compared to those being treated with cabazitaxel. And not only that, they also found there were fewer serious adverse events in the PSMA group. So very promising results. They also reported a significantly longer progression-free survival in PSMA patients as shown here, where PSMA is the blue curve with a reported hazard ratio of 0.63. The VISION trial was reported soon after. This was a randomized phase 3 trial looking at the effects of including PSMA in addition to standard of care in 831 patients compared to 551 receiving only standard of care. I will point out that standard of care here did not include either radium, immunotherapy, or chemotherapy. Patients who received PSMA had to have a positive gallium-68 PSMA-11 PET, and the primary endpoints of the VISION trial were overall survival and radiographic progression-free survival. What they found was a very significantly improved progression-free survival, shown here in the blue curve, compared to standard of care, in addition to a significant improvement in overall survival, also shown by the blue curve. To understand the significance of these findings, it's helpful to put them in context to other phase 3 studies in prostate CA, which have come out in the last decade or so. So if we compare the results of VISION to the other agents, we see that PSMA performs quite favorably compared to other available agents, while also offering a novel mechanism of action. So as soon as the VISION results were published, there was considerable excitement in the community, and there were loads of enthusiastic editorials which were written, but more importantly, the FDA approved it in March of this year, with Health Canada following suit earlier this month. So we now have access to a new product, Pluvicto, which is approved specifically for, and I quote, the treatment of adult patients with PSMA-positive metastatic castration-resistant prostate cancer who have received at least one androgen receptor pathway inhibitor and taxane-based chemotherapy. So there's a lot to unpack in that statement. The first thing to notice is the requirement of PSMA positivity. So in other words, they need to have disease which shows uptake on a PSMA PET. Next, they need to have received both an ARPI and a taxane, which places PSMA relatively late in the game in terms of treatment options. This is largely a reflection of the VISION trial methodology, as is the dosing, which consists of up to 6 cycles of 200 millicuries delivered every 6 weeks. There are provisions made for circumstances which require dose reductions or reduced cycles in the product monograph, and I'll refer you to that for further details. We have to take a minute to point out that there is, to date, no Health Canada approved PSMA PET agent, which puts PSMA therapy on very shaky footing. Until this gets resolved, and I'm optimistic it will be relatively soon, it's likely that PSMA therapy will be available only at specific centers, which already have access to PSMA PET, usually on a clinical trial basis. In the short term, I think we can expect this to be something of an obstacle to widespread adoption of this agent. An additional point that needs to be discussed is the definition of PSMA positivity. I think the assumption is that we should probably employ the definition used in the VISION trial, which was to have at least one lesion with uptake greater than liver on a gallium-68 PSMA-11 scan, while excluding patients with soft tissue lesions with short axis dimension greater than 1 centimeter, or in the case of a lymph node, 2.5 centimeters, with uptake less than or equal to the liver. While some centers may find that acceptable, it should be noted that the therapy trial used a very different eligibility criteria. Ultimately, and this is my opinion, I think it may be too early to tell what the optimal definition of PSMA positivity is. An additional point to consider is that PSMA positivity may be influenced by the tracer being used. So here's a comparison of DCF-PYL versus PSMA 1007. So this is interesting because studies have shown that lesion SUVs are not significantly different between these agents. However, PSMA 1007 has significantly more hepatic uptake, which would make using the liver as a comparative organ problematic. So this may not be an issue if we all find ourselves using PSMA 11 in the future, but it's something people need to be aware of if that's not the case. So there are some lingering issues that need to be cleared up. The good news is that besides the fact that it's an effective therapy, as we've just seen, the workflow is extremely straightforward. The agent is administered in approximately 15 minutes and the patient can be discharged soon after. The radiation safety procedures are straightforward and comparable to other nuclear medicine therapies. Over the course of therapy, it's necessary to do regular blood tests to monitor patient blood counts, liver and renal function, because in cases of adverse drug reaction, it may be necessary to decrease a dose, change a dose interval, or discontinue the treatment altogether. When to do that is detailed extensively in the product monograph. So the most common side effects seen with Pluvicto consist of fatigue, dry mouth, nausea, anemia, and GI changes. In terms of lab work, abnormalities in the patient's CBCs are frequently seen, which is not surprising since most of these patients have extensive marrow involvement, as well as some electrolyte abnormalities. So vision showed us that adverse events are significantly more common in patients being treated with PSMA in addition to standard of care. Of note, a not insignificant number of subjects experienced PSMA dose reduction, dose interruptions, and dose discontinuations at rates of roughly 6, 16, and 12% respectively. Also important to note is that 3.6% of patients died while following an adverse event in the PSMA arm. So before everyone rushes out and starts treating patients with Pluvicto, it's important to keep in mind that there remain a few unresolved issues. As I mentioned earlier, there's still no Health Canada approved PSMA PET agent. In addition, the interaction between radium, chemotherapy, immunotherapy, and PSMA is unclear. Patients on these agents were all excluded from the VISION trial, and we don't have strong safety or efficacy data to guide us on how to approach combinations of these agents. I'm hopeful that additional studies will help lead the way, but as of today, I think it remains an open question if these agents can be used in conjunction with PSMA. Finally, we have to ask ourselves how best to roll out PSMA RLT programs across the country. So the folks at AAA have asked me to talk about the future of PSMA. It's challenging. I'm not a psychic, but I'm willing to give it a shot. On that note, I'll share with you my top 5 predictions for PSMA therapy in Canada in decreasing order of likelihood. So my top prediction is no surprise. We will be doing a lot more therapies in the future. That's a rather obvious prediction given the topic of the session, but I think agents like Pluvicto and Lutathera are really just the tip of the iceberg. There are more agents coming down the pipeline, and I suspect that the next few years may be transformative to our specialty. My second prediction is also no surprise. PSMA PET will become more widely available. It has to if we want this therapy to be successful. Increased access to PSMA PET may very well be accompanied by increased access to PET in general. And that would be another huge advantage to our specialty, particularly in those provinces that don't start with a Q. I think it's highly likely that we see additional PSMA RLT agents developed in the near future. The reason for that is shown in this table, where the leftmost column denotes PSMA 617 in addition to a number of other agents, many of which are currently in trials. Furthermore, this list is far from being complete. Given the results seen with Pluvicto and the relative importance of prostate cancer in oncology, I think it would be surprising if we didn't see new prostate RLT agents emerge in the next few years. I think we can also expect to see alternate choices of radionuclides in our PSMA agents. If we look at this table again, we see that most compounds can be combined with multiple different radionuclides, some of which include alpha emitters. We know that alpha emitters are generally favorable to beta emitters due to the short range of the alphas and our high linear energy transfer. And there are sites that are currently looking into producing alpha emitters, such as actinium-225, for example, which I think is one to watch. Finally, there are a number of studies looking at the combined use of PSMA with androgen receptor axis targeted therapies, DNA damage repair inhibitors, and immune checkpoint inhibitors. I think it's likely that at least some of these studies return a positive result, and this could have a big impact on how we approach PSMA therapy. So at this point, I'll thank you for your time, and I'll hand it over to the moderator.